monofocal and progressive IOL, which looks like monofocal but works like real multifocal. Its progressiveness is very similar to varifocal spectacle lenses. It's an oval or ovoid shaped IOL which is 6.3 mm vertical by 7.5 mm horizontal, progressiveness of which is achieved by gradient refractive index technology. There is a stepless or jump-free power distribution in the main optic of this IOL. And as we can see, at any size of pupil, ratio of light energy distribution remains the same. These two dialing holes are also positioned in solid and absolute rotational stability, and the large optic covers full visual field without leaving any aphakic zone, and hence this IOL is totally free from negative dysphotopsia. Autofocus Pro, although being a progressive multifocal, has MTF value of 0.65 for distance, 0.4 for near, at 3 mm pupil size, at 50 lines per minute, and thus IQ, the image quality at retina and Autofocus Pro is available as both versions, hydrophilic, non-preloaded with disposable injector and cartridge, which are in the box, and also as hydrophobic preloaded with push or screw dual mechanism injector. This silky, smooth and soft IOL's injection is very easy, as good as any other soft foldable IOL. And as you can notice, unfolding is gentle and slow, and once both haptics are in the bag, we have to rotate the IOL so as to keep both dialing holes in upper half of eye, keeping the IOL horizontal as best as possible. At any size of pupil, the light distribution proportion remains the same, and hence it is pupil independent. There is no light energy loss because there is no destructive interference or diffraction, and angle kappa or angle alpha are of least significance or importance. This is the only ringless progressive IOL having all zones in central 0.9 mm area, and hence it is independent of any pupil size. This is the typical post-op fogging over refraction chart, and as we can see that from +2 to -4, the vision remains almost the same, which is almost like 6 diopters of amplitude of pseudo accommodation. This is the typical DOF chart of Autofocus Pro, which is almost flat from +2 to -4, which is nearly identical to a teenager's natural lens DOF. With crisp and clear vision at all distances without any negative or positive dysphotopsia, Autofocus Pro is also a presbyopia correcting IOL. All near vision intensive vocations become spectacle free and as easy and as clear as a teenager. There is no need for mono, micro mono or mix and match vision. Autofocus Pro is also the best choice for kids. These children will need only monofocal spectacles to correct the gradually increasing myopia. They will never need bifocal or progressive spectacles, which is a big recurring expense for parents for over 2 decades. And there is no waxy or hazy vision, so no induction of mild amblyopia. We can implant this lens in one eye or in both eyes because it is so well accepted, just like a monofocal, without any neuroadaptation time, and it can be considered as a super EDOF or EDOF Ultra or EDOF Plus IOL. Phaco or MSICS Autofocus Pro is the best choice IOL. To conclude, all other IOLs are gems, but Autofocus Pro is the jewel of the crown. Thank you very much for your kind attention and patient listening.
Thank you. That was a good presentation, Arvind. I just have one question. How do you think, which category would you put in the sense that we have advanced monofocal, then we have trifocal, multifocal? What would you call it? Is it a kind of a...
It is a polyfocal progressive IOL without any refractive or diffractive ring and no posterior apodization. It's a polyfocal progressive IOL.
Polyfocal progressive IOL.
Yeah. Thank you.
You did mention that it can be very useful for pediatric
Yes.
thing. So do they adapt easily? Like we've always been very concerned about using multifocals in pediatric.
They adapt it very well,
eyes.
sir. We are implanting in 10 plus year of age group, and they are accepting
Okay,
it
so
really
the cutoff
well.
is 10 years?
Yeah,
And
no
is it always-
neuroadaptation is required.
And can it be used unilaterally or it's always used bilaterally?
Both the options
Can
are
be used even unilateral if one eye is absolutely
yes,
normal?
yes,
Okay,
it can be.
perfect. Thank you.
Thank you.
So I think second one is also yours, is it? The second presentation is, have you already presented this novel, small and effective drainage device for complicated open angle glaucoma?
No. I need to search it. Kindly call the next.
Okay, thank you. Hello. Yeah. Thank you so much for giving this opportunity. And I'll be showing you two of the cannulas which are modified by me, and they are manufactured by Epsilon. I don't have any financial interest in the product, is that only my name goes with this. So this is the first, this is a dark viscoelastic cannula. So how it's different from other cannulas is that it's made of 25 gauge, and it has a smooth curve and a tapering end, as you can see here. So the advantage is that it goes easily through our side port incisions, 1.2 mm incisions, and it has a smooth curve, so we get a wider and deeper reach in the capsular bag. And this is the second cannula, which is hydrodissection and hydrostitch cannula. So let's see in videos. So this is on this side is the normal viscoelastic cannula, which is difficult to insert through side port, and you can see you can't go beyond this area, beyond capsular access margin, because of this curve here. But because of the smooth curve of this modified viscoelastic cannula, you can reach deeper. So if I go from side port, I can easily reach because of the smooth curve of this cannula. So it's ergonomically designed that whenever we need in situations like this is hydrodissection and hydrostitch cannula. It's bent 1 millimeter at the tip. It has 85 degree of angle here. So you go on one side and do hydrodissection and turn it around and do, you can easily do sub-incisional hydrodissection also, which is very useful in softer cataracts where it's very difficult to do hydrodissection. And at the same time, you can bend it downwards and rotate the nucleus. In softer cataract, you can also do hydrodelineation with this cannula. This is a softer cataract. You'll see I'm just turned the bevel down and I'm doing hydrodelineation with this cannula, and this endonucleus pops out. So here some epinuclear sheet is there. So you can see that I can easily reach to deeper level, and epinucleus shell, it comes out. So it has a smooth curve which makes it very easily accessible, entire capsular bag. If you have a zonular dialysis, you need to go deeper to push the equator back. It's very easy. So this epinuclear sheet prolapses out with this cannula. You have situations like anterior capsule tear and all those posterior cataract where you don't want anterior chamber to collapse. So it's very easy to insert through side port incision. Again, epinuclear sheet is there. I go from side port, go deeper down and do visco expression. If you need to maintain chamber, it's very easy to insert through side port, where with the normal cannula you need to struggle. And this hydrodissection cannula is also hydrostitch cannula in the end. You can easily hydrate all the walls of the incision just by rotation of the tip of this cannula. And it's especially useful for topical phaco, which we do most of the time, where cases have where palpebral opening is not that much and patient is rolling eyes upward. So it's very easy to hydrate all the walls of the incision with this cannula. So this is how it's used. Look here. So this is a normal hydrostitch cannula which we use. But once we try to hydrate this wall, it's very difficult to angle the cannula, especially in topical cases. But with this cannula, you can just insert it in the incision, just turn it right, left. You can hydrate all the walls of the incision very easily. Look at this case, eyes is rolling upward, but you just need little exposure to do hydrodissection. So I've been using these cannulas for last 1.5 years now, and they are very useful, and they make surgery very simple. So I think with this I'll end my presentation. Thank you so much.
Thank you, Harshal. Very nice presentation. And I think, what is the gauge of this cannula?
So this hydrodissection cannula is 27 gauge.
27, okay.
Whereas the visco cannula is 25 gauge.
25?
And it's tapered at the end. And it has a Leo lock mechanism. So it's always important that you, just on syringe, you just screw it with the Leo lock, because of the smaller gauge as compared to the normal cannula, little more force is required. But within 15-20 days, you get used to that force. It is very useful.
I was wondering that since most of us do make side ports which are at least 23 gauge, so I mean the visco could be even like 23. Have you tried 23 gauge, which would also allow easier, kind of this thing, and yet go from a,
yeah,
smaller
I've tried that also, but our incisions are 1.2 millimeters, and this goes very smoothly
very nice.
through that. Yeah.
Thank you.
Thank you, Harsh.
Thank you, ma'am.
I think Dr. Arvind is ready with the second presentation.
He's already
We are happy to present OmniFlow, which is a novel GDD, a valve tube shunt, to drain aqueous humor from anterior chamber to the retrobulbar space. A micro valve tube pressure regulator is fitted inside a soft silicone tube, which controls the outflow of the aqueous humor, which will prevent hypotony and maintain the IOP between 10 and 24/7 without or with minimum number of topical anti-glaucoma medications. This is how the OmniFlow tubes look. This is the anterior chamber end, this is the retrobulbar end, and the tiny pressure regulator is inside the tube. Retrobulbar space behind the equator is almost free from myofibroblasts, hence it is virtually free from fibrosis, even without mitomycin C. Retrobulbar space can easily drain up to 500 microliters per minute without engorgement, proptosis, or chemosis. Aqueous humor production and outflow discharge rate is only 3 microliters per minute. Hence, retrobulbar space can easily drain 170 times more fluid than the aqueous humor production. Let us see few videos of OmniFlow. After putting L cut in the conjunctiva and after a little blunt dissection, insert a vectis to reach the retrobulbar space, which is very easy. We can insert almost 40 mm of rectus which goes into the retrobulbar space and creates a track. A gentle bipolar cautery is done. Now we make one scleral tunnel which is made by angled MVR 20 gauge 7 mm away from the limbus at 45-degree angle. The tunnel is now lubricated with viscomethyl. The beveled end of OmniFlow is now inserted in and passed through the scleral tunnel. Three-fourths length of the tube is pulled out. The valved end of the OmniFlow tube is inserted into the retrobulbar space. It goes quite easily as if a rope is falling into the well. The excess length of the tube is pulled back and pushed into the retrobulbar space. Now a second scleral tunnel is made which is radial or perpendicular to the limbus, about 2 to 2.5 millimeters from behind the limbus, which is then entered into the anterior chamber, bisecting the angle between the endothelium and the iris. The beveled end of the tube is now inserted into the anterior chamber via the second scleral tunnel. Only the bevel goes into the anterior chamber about a millimeter or 2, maximum 2 millimeters. Then the excess bend of the tube is pulled back and which is then pushed back into the retrobulbar space. The firm anchoring of the tube is confirmed by vigorous pull, push and sideward movements, and as we can notice here, no matter how much we nudge, the tube will not budge. The tube cannot be pulled out unless we want to pull it out. It's firmly anchored, it's not going to migrate, it's not going to move on its own. Now we put fibrin glue and the conjunctiva is reposited back. The entire surgery for this is sutureless and it takes only about 10 minutes to do the surgery. Hypotony, never. So hypotonic choroidal effusions, never. Hypotonic maculopathy, never. Silicone oil induced glaucomas, severe rubeotic neovascular glaucomas, multiple failed TRABs, and traumatic angle recession glaucomas are the best indications of OmniFlow, and they are best served by the OmniFlow. In this one-eyed young patient of severe Sturge-Weber syndrome, after 4 failed TRABs, OmniFlow saved the only working eye. OmniFlow tube is not just biocompatible, it is biointegrable, so there is never any tube exposure and there is no need for any patch graft over the tube. Thanks a lot.
What is the thickness of the tube?
It's 0.7 outside lumen and 0.1 is the main lumen. And the Teflon wall is there fitted at the retrobulbar end. So that is 175 to 250 micron. Length is 50 millimeter. So which length to be implanted? So it's axial length plus 5 millimeter. That is the formula.
Okay, and the chances of infection because you are...
No chance.
Because once you are inserting, it's inside the eye it is open, right? You are in maybe retrobulbar you are fitting it under the conjunctiva, but inside it is open. When you are putting it inside, so any chances of infection you have seen?
No, we have implanted now all over India. It's more than 1,000 implantation. No, not a single case. No. It's working very well in the most refractory of the open angle glaucomas like the neovascular glaucoma, the silicone oil induced glaucoma, the Sturge-Weber Axenfeld-Rieger syndrome, and even the primary ophthalmos cases. It's working well. And the main advantage is the side effects of trabeculectomy are not there, like the choroidal effusion and detachment.
So size differs in the ophthalmos and all?
No, it's the same. It's the same. And no requirement of mitomycin C because we are exploiting The retrobulbar space, that is almost free of the myofibroblast.
Thanks, Dr. Arvind.
Thank you.
I'll invite our next presenter. Is Dr. Santosh Kumar here? Dr. Santosh Kumar? No? Okay. So we'll go on to Dr. Ranjit Daliwal. Should I call the next person? Oh, you're presenting from there? Okay. Please come. So Dr. Ranjit Daliwal is presenting on OT mask for bearded and turbaned eye surgeons. Very interesting.
Good morning. Someone said on one of the WhatsApp groups, when are we going to ban the bearded and the turbaned surgeons from the IOTs? So I made this video, though we've been using it for the last 43 years. No innovation of mine. The whole department used it. Sound.
I'll also request the next speaker to be ready on the other side is Dr. Kumar, Dr. Shivani will.
And eye surgeons from the IOT. Good morning, friends. Before somebody bans us, bearded and turbaned eye surgeons from the IOT, I thought I'd better demonstrate the mask that we've been using all these years, all these last 45 years. This is a plain green cloth. We place it on top of our turban, pull these two side strings, lower end of the cut is placed on the nose, and we tie it at the back of our head on top of the turban with a double knot. You could even ask one of your assistants or friends to do it for you. Literally that's it, but the loose flap would come into the field and obstruct your vision. So we pull it towards the back and tie it again with two double knots, and that's it. We could even pull it back to tighten it. Here I've kept it loose. Thank you for patient listening. Good morning, friends.
Thank you, Dr. Daliwal, sir. It's very interesting, actually. And I think for turbaned, bearded gentlemen, definitely a very useful innovation. So I'll invite the next speaker. I think Dr. Shivani is representing Dr. Kumar, Dr. Submission. I'll also request Dr. Bhavesh, sir, to be ready on the other podium, please.
Good morning, everybody. This is a bimanual that has been modified by Dr. Kumar, Doctor, and I'll be presenting the video on his behalf. Dr. Kumar, Doctor. Sir, I think you move on. I'll present after them. I think you go to the next one. They can't find me.
Okay. So we'll request Dr. Bhavesh to present first. And while they find it, we can also request Dr. Rishi Swarup to there. Okay. Is Abhijit, you would like to put it up there? Okay. Okay. So I think we have found it.
For successful phacoemulsification, it's important to have a perfectly circular centered capsular rhexis, followed by hydrodissection, and then followed by the hydrodelineation and the creation of the golden ring. Followed by in-the-bag phacoemulsification and a bimanual IA for a well-centered IOL in the bag. The original coaxial IA can be straight or 45-degree angle, followed by a bimanual IA invention. Following femto CCC, there is a change in technique for IA compared to manual CCC. In manual CCC, one can easily notice the free-floating fibrils of the cortex beyond the margin of the CCC, which are aspirated with the solid straight coaxial IA, or one can use a 45-degree coaxial IA with a sleeve, or even use a bimanual IA to hold on to the free-floating cortical fibrils to aspirate them. With the invent of the femto-CCC, there is a change in technique for IA. With the aspirating port, one has to reach below the CCC margin, grasp the edge of the cortex, take care that the anterior capsule margin is not held, and aspirate the cortex to complete and perform the IA. Notice the edge of the CCC. In flax, the rexis size or the height of the resection can be adjusted from 600 microns to 700 microns or 800 microns, or even 1 millimeter above the CCC. We normally keep it at 600 microns, so it's 400 microns above and 200 microns below the anterior capsule. Post-flax, let us see the anterior segment OCT, where we see a free-floating CCC and a free-floating disc of cortex of 200 microns. In this case of a femto-CCC, notice a disc of 200 microns of free-floating cortical matter, which is now being actually elevated and separated with the help of the viscoelastic. So there are no free-floating fibrils below the CCC, which are seen in manual CCC. So the technique changed for IA, which is essential but subtle. Post-flax, to perform bimanual IA in a well-dilated pupil, one can easily hold the cortical matter just below the margin of the anterior capsule and aspirate the cortex. Let's look at a case of flax in a very hard cataract. During phacoemulsification, the pupil constricts below the margin of the CCC. So now the problem begins. Here we are using the irrigating cannula to hold the constricted iris away, but due to poor grip, it keeps slipping and makes it difficult to do cortical aspiration. Look at the struggle, and the iris keeps slipping. One can use a solid coaxial IA and use a Y in the other hand to retract the iris, hold the cortical matter and aspirate it, but it is difficult to access all the corners of the bag in such a technique. So we invented the irrigating Y. To the irrigating handle, we attached an attachment like a Y, and this attachment actually helps to hold the iris away. With the aspirating port, we can go beneath the margin of the CCC, hold the edge of the cortex and aspirate it. The design of the irrigating Y is in such a fashion that the PC is kept away because of the flow. The procedure continues. Again, the iris is held with the Y portion of the irrigating handle and the cortex is easily aspirated. With change of hands, the procedure is repeated, iris is gently retracted, the anterior capsule margin is visualized and the cortex is aspirated. The technique is very simple. Use the standard MVR to create 2 ports. Use the irrigating Y in a horizontal position and enter the anterior chamber. Then orient the Y vertically and go ahead with the aspirating port to hold the cortical fibers and continue to do a bimanual IA. Here is an example of using the irrigating Y. Another case where the femtorexis is performed, let's look at the use of the irrigating Y. The Y attachment gently retracts the iris and one can go beneath the CCC to hold the edge of the cortex and aspirate it. The beauty of this design is to be able to access the entire capsular bag all around. While going across, retract the iris, visualize the cortical matter and then aspirate it safely. One can access 180 degrees all around. With the change of hands, the irrigating Y can cover the other 180 degrees of the eye. So the entire 360 degree of the bag can be accessed due to the design of the instrument. Thus make sure that no cortical remnants are really left behind.
Thank you, Shivani. That's very innovative indeed and very useful, I think, especially in femto cases where your cortex can be troublesome to access. Right? Thank you so much. So we'll go on and we'll have Dr. Bhavesh.
Good morning, everyone. I am going to present my innovation for identification of Schnell canal.
In conventional trabeculotomy, accurate localization of Schlem canal is the key to successful surgery. Tips to identify the Schlem canal is blue-white junction at surgical limbus. presence of perforated vessels and slight depression over Schlemm's canal. Horizontal corneal diameter less than 13 millimeters. The anatomic abnormality of Schlemm's canal is usually not significant, facilitating its easy identification. Abnormally stretched limbal anatomy in ophthalmic eye makes it difficult to identify or may not be found in 1/3 of case at all. Here we innovated new technique that is 25 gauge light pipe for correct localization of Schlemm's canal. Before introducing Hum's trabeculotome, 25 gauge light pipe being introduced into Schlemm's canal. Illuminated microcatheter can be used for exact localization of Schlemm canal and to perform 360-degree trabeculotomy, but it is costly and not available in India. Here we are using uncovered tip of 25 gauge light pipe that is widely used by vitreoretina surgeon for pars plana vitrectomy. 25 gauge light pipe easily available and can easily insert into Schlemm canal to know the exact tract of Schlemm's canal to prevent inadvertent entry of Hum's trabeculotome into anterior chamber. At the end, Hum's trabeculotome if being introduced to complete the trabeculotomy. To conclude, 25 gauge light pipe can be used to know the correct tract of Schlemm canal. Thank you.
It was quite innovative. And Ashish, you have any question, or Dr. Ajay?
I'm just curious that this is a fiber optic 25 gauge?
Yes, sir. This is the fiber optic.
This is different than the...
No. This is the 25 gauge fiber optic used for vitreoretina surgeon. Okay. I have just peeled the cover up and then using for this.
Okay, you have peeled that off. Okay, that's why.
Yes. No. Actually, it is for that it is already available micro catheter, but not available in India. That's no. It is a little bit harder. It cannot possible to go 360. Just for identification you can use. But I can try in 27 gauge. I will try for 27 gauge. It may go through 360 degree.
The first deep vertical cut you are giving. So what are you doing for that?
Sir, this is for trabeculotomy.
No, that's fine. But once you have done it, then do you suture that or what?
No, sir. This is for this is the method for doing trabeculotomy. This is same method to identify the by giving the vertical incision. We have to excise the anterior part of Schlemm canal, and we introduce
what finally you close it as it is. How long is the incision? Okay.
After doing trabeculotomy, in India we used to do both combined trabeculotomy plus trabeculotomy. That after doing doing trabeculotomy, I go for trabeculotomy also by cutting and by then repair the scleral suture as like in trabeculotomy.
Okay, thank you.
Thank you, sir.
So I think we'll have Dr. Rishi Swarup next, and I'll request Dr. Abhijit to set up his presentation on the other podium. So Dr. Rishi is presenting on novel push and invert technique for soft cataracts.
Thank you. At the outset, I'd like to thank the local organizers and AIOs for the opportunity. So this is a very simple technique, and I'm sure all of you will find it useful if you tend to struggle with soft cataracts. So, we all have some problems with soft cataracts. When you're trying to emulsify them, they tend to, get cheese wire. If you're trying to get a grip, often you end up creating a crater, and you don't get a purchase to emulsify the nuclear material. And if you keep chasing it, sometimes you can end up catching the capsule, you can injure it, and sometimes the case takes longer than you would like to. So to circumvent this problem, people use some techniques like prolapsing the nucleus with either viscoelastic or hydrodissecting it out of the capsular bag, and then completing the rest of your procedure with an IA probe, etc. or you just be at it and continue chasing it with the phaco probe using aspiration. But while I used to do all these, I kind of stumbled upon this technique which I now modified from what I used to do, and I found that this works almost every time in soft cataracts. So I've given it the name of push and invert technique, and I'm sure many of you may already be using it, but nobody has described it, so let's see. So what we're doing in this basically is you're going into the depth. So once you've divided your nucleus into two heminuclei, you're going into the depth of your nucleus, and at the bottom half, closer to what would be a posterior plate, is where you would give a kind of lateral pressure. And as you press this nucleus, it actually rolls against the fornix of the back. The animation is not great, I made it myself, but basically what it does is, because the fornix of the bag is round and your nucleus is round, it rolls against it as you apply lateral pressure, and it actually prolapses, and the equator of the nucleus actually comes up, and then you can emulsify it from there. So I'll just show you a couple of videos how that works. So in this case, we tried to do phacoemulsification, but it was cheese wiring, and then using a visco cannula, and you can also inject visco as you do this. You see, I applied some pressure and the whole thing rolled up. I'll show you more videos too. And then you basically grab the equator and emulsify it from that end. So this works very well actually. Even for regular cataracts you could use it, but you don't really need to for grade 2 onwards. But for soft cataracts particularly, I think it's really useful, and you don't really need to struggle getting that nuclear piece or whatever it is out of the capsular bag, and to get a purchase for emulsifying. So just to demonstrate again, so if you're trying to do it with a phaco probe type of an instrument, it won't happen because it's too thick, and you don't really get that posterior pressure that you want. So you see now I'm doing it with the Sinskey hook, or you could use a spatula, and the irrigation is on, and it just rolls against the fornix of the bag, and it comes out, and you then grab the equator and emulsify it. So it works every time. I mean, this is my go-to now, when anytime, even if the vacuum is not great, if I'm using not a very great phaco machine also, I just do this and it works almost every time. So you can just see the other side. Again, I'm just for purpose of demonstration, I'm showing you, I'm trying with the phaco probe, it doesn't work. And then you try with the Sinskey hook, which I'm using now, and it rolls against the fornix and comes out. So it's very good, and I think it's very easy for any surgeon. So the key is to be in the posterior half of the nucleus and apply gentle lateral pressure. Don't worry, you won't cause zonal dialysis, because it's round and the nucleus is round, it will roll. And this is just a case of a femtosecond laser where the 4 cuts have been made, and just visco is being used to separate, and with the same cannula, I just turn the piece out, and then you can just emulsify it the same way. So essentially that's it, a useful technique to tackle soft cataracts. For very soft cataracts, you can use a OVD cannula and inject OVD as you're doing this, because otherwise if you just use like a Sinskey hook, it may cheese wire again. And for grade 1, 2, you could use a spatula or Sinskey hook with the irrigation on in your phaco probe, or you can again use a cannula if you like. That's about it. Thank you.
Nice, very nice, Rishi. It looks so like intuitive. Anyway, I was wondering, why do you say that the phaco tip does not work? Because, you know, I felt...
No, it would work, but you have to be at it. You have to be at the exact posterior part of the nucleus, and, you know, because it's a big instrument, it's not as easy. It would work, but you have to be at the absolute posterior end of
So what you are recommending is use a chopper or something, or a dialer?
Not a chopper, something blunt. So since you
a
spatula,
white-tipped
white-tipped cannula would work beautifully. Yes, yeah. Or Herschel's cannula.
Right, Herschel.
The visco cannula. That would work very nice.
Right. You've given an idea to him now.
Yes. Thank you.
Thank you so much. Any other question, Ashish?
Just a basic question: that what the IOP in the anterior chamber at that time we shouldn't fill it with visco or anything. If you're using not the phaco probe or not a irrigator.
I don't think it makes so much of a difference.
Does it matter?
Yeah, but in general, you never want to hyperinflate the AC for any step of phacoemulsification.
So that would be important, not to hyperinflate.
Slightly softish, yeah. So that it won't push it back.
It doesn't push back.
Does it happen equally easily? You showed it even in a heminucleus.
Yeah.
So does it work in a particular size of a
in quadrants? No. So I use it for quadrants also sometimes. So if something's stuck, you've created a crater, just roll it out.
Pretty good.
It works.
Thank you. Thanks. So we'll go on. We'll have Dr. Abhijit presenting next, and I'll request the next presenter, Dr. Sheetal Brar, I think. Yes, Dr. Sheetal, to please set up her presentation.
Can we have the slides? So we are going to talk about a novel irrigating CCC forceps. So the idea came from our presentation in which we had done a comparison of viscolis phacoemulsification and versus a soft shell technique in grade 1 to 3 cataracts, and we realized that there is hardly any difference in the endothelium health pre and post the surgery. So it was taken as a very safe technique to be done. So why viscolis cataract surgery is essentially because of the BSS is the most endothelial friendly material, better than even the OVDs. TASC is mostly from viscoelastics. This technique is used in NS 1 to 3 cataracts. Also OVDs trigger IOP spikes and can trigger inflammation in the eye as well. So the challenges for viscolis was mainly the capsular axis, maintaining the chamber during the CCC and the flutter that happens with the flap. And we found it useful even in intumescent cataracts, and this device overcomes these issues very easily. So let's see how that goes. So when we started doing viscolis, this is how we were going about it with the side port and the needle. And sorry. And with that, if you see, it's very difficult to turn and maneuver the entire axis with a needle using just the irrigation. And you can see that flutter which is happening there. And it's not easy to manage the CCC using these, this device. So we thought that maybe the leakage from the side port is the one which was causing this problem. So we tried it with a thicker needle. So when we tried with the thicker needle, even then the problem was the same. The flutter and the management of the rhexis was very difficult. So though it is completed, it's very difficult to manage these things. So we designed a metal prototype with a irrigation attached to the forceps itself, the microvitreal forceps. And we found that worked very well, maintained the chamber very well. But because of the metal, if you see in this quadrant, wherever the forceps is being rotated, you lose the track of the rhexis out there completely. We'll see it again out here. So the visibility at some stage goes away whenever you're doing this, using this forceps, this prototype. And again, many a times this used to come out of the wound, and that used to give a problem. So we used the second prototype in which we designed it as a coaxial one, in which we could use the phaco sleeve over the same forceps. And we realized that this was much better. Now here I'm using, these were the initial stages where I'm using the irrigation port, an additional irrigation port, because we were not sure how they would work. And slowly, as we got confident about the efficacy of the flow, we shifted to purely the coaxial ones. And in fact, you can use the second hand with the aspiration port, like what I'll be using here. So this, we changed the design of the tip because we could take the sleeve much more inside, so the flow is much better. And here I'm using the second hand with the aspiration port to support, because all these are topical cases, they give you a good stability. And you have good control, you can move it easily, doesn't give you the flutter that was giving with the irrigation and the cystitome, and you're able to easily complete the rhexis. So let's see how that works in intumescent white cataracts. So here I'm using an additional irrigation to increase the IOP in the eye with a dual in this one. And we've made the first nick. So far so good. So in these cases, I also sometimes feel we can use the aspiration port to, after the nick, to use the aspiration port to remove off the fluid in these cases. And we are able to manage this very easily. And the rhexis at no time seems to be going in the periphery. So now here is a grade 4 to 5 brown cataract. And again, the CCC is behaving very well in this, with this instrument. So what does this forceps help with? It's a normal microrhexis forceps. You can use it with through the side port as well. You can use your normal phaco sleeve over it. It's another novel technique, and especially for those who want to do viscolar surgery, it's another instrument for difficult scenarios. And it can also be used to peel PC plaques. So you can actually go down and maintain the chamber while peeling off the PC plaques. Thank you.
Very nice, Abhijit. And I do something similar, but not with such a fancy instrument. What I do is I have calibrated side ports. So I have two side ports. Both are calibrated to my instruments. One will take a 22 gauge infusion, which is my knives are also 22 gauge, which is 1 millimeter. And from the other port, I have a 22 gauge microrhexis forceps.
Yeah.
So basically what that does is the same thing as what you are doing. The chamber is stable. So if you don't have any fluid getting lost from the chamber, there's no fluid flow happening, that thing flutter won't happen.
Yeah.
So your chamber is going to be rock steady.
So here the advantage is you can use the aspiration port to hold the flap as well.
Right, I agree. So for me, how that works better is that because I can switch hands with the microrhexis forceps if I want to.
Yeah.
Okay. Because suppose I want to access an area
Change
where
the angle,
so I can then access. But the main thing, take-home message from here, I think, is that your chamber should have stable chamber
IOP.
with no fluid loss happening from any port.
Yeah.
And that sets up, and it's a brilliant innovation.
Thank you so much.
So, any question from Ashish?
No, I would just like to congratulate Abhijit. You're an excellent surgeon. I mean, doing this rhexis in such a turbulence is not a joke. Excellent.
Thank you so much.
Very nicely demonstrated points. So, we'll go on now to our next presenter. That's what I was saying. It was a beautiful round rhexis in spite of the flutter. Right? Dr. Sheetal Baran, she's going to present a safety net device for PCR management during phaco.
Thank you, sir. Good afternoon, respected chairpersons, dear friends. I would like to thank AIOC for this wonderful opportunity that gives me a chance to present a small innovation that I've done in cataract surgery. I would also like to acknowledge Dr. Sri Ganesh as the co-inventor of this innovation. No financial disclosures. So PCR unarguably is one of the most devastating complications of phacoemulsification that results in a gamut of complications such as vitreous loss, nucleus or fragment drop, eventually leading to a retinal intervention that can lead to a lot of collateral damage in the form of CME, uveitis, secondary glaucoma, also challenges with IOL placement, and all this eventually results in a delayed visual rehabilitation for the patient as well as increased cost of treatment for the surgeon. Now, this is normally what we do when we have PCR during phaco. Either we create a scleral tunnel or we extend the clear corneal wound itself, then we express out the fragments, and then of course we have to suture this wound. So it leads to increased astigmatism, risk of infection, delayed healing, etc. Or if we do not want to increase the wound, what we like to do is that we elevate the nuclear fragments over the iris plane, and then we do a careful phacoemulsification using low fluidics parameters. However, this can be quite risky and can result in a high risk of nucleus or fragment drop. Now, my safety device essentially is a temporary rescue device that can be used in the face of PCR during phaco. So it's made of a biocompatible, implantable, foldable hydrophilic acrylic material. It's circular in shape, and its overall diameter is 7.5 millimeters. So in the first version, which is on the left side, it had square-shaped holes, and each hole was 0.8 into 0.8 millimeters. And on the right side is the version 2, wherein the device has circular holes, smaller circular holes filling the device. Each hole is 0.45 mm, and 4 larger holes, each of 1 millimeter in the periphery. And the thickness of the device itself is 0.2 millimeters. Now let us see a real case scenario where these devices were used. So here you can see almost a grade 3 cataract, and there was a PCR. So of course I lifted the pieces above the iris plane, did an anterior vitrectomy. There was some amount of vitreous there, and then loaded the device onto a 2.8 millimeter injector. Any regular injector can be used, and I positioned the device over the iris and under the fragments, and you can adjust it with the iris hook. And then now you need to secure this device. You cannot just use it just like that, because otherwise the device itself can dislocate if you, when you are doing phaco. So generally, you can just fixating it at 3 points is good enough, because on the fourth side, on the other side, the pieces itself can, they will stabilize the device. So once the device is secure, then under good OVD cover, you can go ahead and complete your phacoemulsification without the risk of these fragments dislocating into the vitreous cavity. So of course, once the job of this device is done, you just need to remove the iris hooks and pull it out using a forceps. And then now, of course, you can do a proper thorough anterior vitrectomy, look at how much is the collateral damage, see the condition of your rexes, and then plan your IOL. And all this is done without extending the wound. Now this is the use of version number 2, where this is a soft cataract where there was a PCR, and I have inserted the device under the fragment and positioned it over the iris. So you can see the size of it is around 7.5 mm, so it usually covers the pupil well. So securing the device with iris hooks. So anyone who is familiar with the use of iris hooks can actually use this quite conveniently. And yes, now you can go ahead with your phaco. Take the hooks out and just pull it out. It's made of a soft hydrophilic material, so no problem with the explantation. So potential advantages of this device could be PCR can be managed without extending the clear corneal wound, hence wound related complications would be minimized. Thorough anterior vitrectomy and cleanup can be done after management of the fragments. IOL can be planned after proper assessment of the collateral damage and available support. It's hydrophilic material, hence very flexible, easy to maneuver. And it's a very simple device, easy to load, easy to insert, as well as explant using either a regular 2.8 or a 2.2 millimeter injector. Hence, it is quite user friendly as well. Thank you so much for your attention. So I think it's a useful device even for beginner surgeons who tend to have more complications.
I think yeah, excellent device, I think I'll say. But use of iris hooks, definitely one should know. Otherwise, I feel yeah, it is good. Something.
Thank you, sir.
Yeah, I just beautiful device, Sheetal, I think. But I just had a question. In the cases that you demonstrated, you didn't do any vitrectomy before.
I did vitrectomy
before
because of the
or after removal of the fragment.
Of course, before inserting the device, you have to make sure there is no obvious vitreous prolapsing from the wounds. Right. So you will do little bit of anterior vitrectomy if there is vitreous, and then insert the device. You don't want the vitreous coming out of the wound and then inserting the device. So make sure that at least there is no obvious vitreous. You can stain it with the triamcinolone also to check that. But of course, once this is once the fragments are removed, then it makes it much easier to do your vitrectomy, check the available support, look at the condition of rexes, then plan the IOL. Because with the IOL scaffold technique, wherein you use a 3-piece IOL to scaffold the pieces, the limitation is that you will have to use a 3-piece lens first, which is expensive lens, and then you have to insert one haptic and the optic inside the chamber, and one haptic will be outside. So you'll have to keep adjusting it firstly so that it covers the pupil, fragments do not fall, and during that maneuvering sometimes you can damage the lens itself and render it useful for the fixation.
So what's the cost of this device?
It will be marketed very soon, so it will be affordable for sure.
The size is 7.5 you said?
Yes.
So it works in all types of dilated pupils, or you find maybe?
Most of the times when this happens, our pupil is usually dilated, and 7.5 is I think it's a decent size of the device, because if you make it too big, then again sometimes if the eye is small, then it can go to the angles and may lead to more manipulation in the periphery. So I think it's an optimum size of the device.
Thank you. Thank you.
Thank you.
Why can't you just put it on the surface?
No, I mean, still it can dislocate. See, when you're doing phaco, you have the fluidics, everything, yeah, the device itself can dislocate. You need to secure it with something.
In fact, I usually put, if my rhexis is intact, I just use the IL scaffold. I put a 3-piece into the sulcus, and that also works the same way. And then later on, I can just do clean up and, sometimes capture it into the posterior capture or whatever. So I think it depends on the situation.
One
I think
needs to be very skilled also
no.
to
I mean,
use the 3-piece lens and not
in various
damage.
situations, you can use different things. So this would be very useful when, if your rhexis is broken and you don't have the option of putting a 3-piece haptic into the sulcus, then, maybe
because
this
then
will
you
become
are forced to use a 3-piece lens for fixation, and many of us may not be well versed with the techniques.
Thank you.
Thank you, sir.
So we'll invite Dr. Anaga on the right podium and Dr. Sonu Goel on the left podium. Dr. Sonu, please take stage.
Thank you so much. Actually, this is not an innovation, it's just an observation, but I thought I would like to share it. So this is a patient where we have done a flax procedure, and now we would be doing a gentle hydrodissection. Already there is an immodelineation done, and phacoemulsification is complete, irrigation aspiration, and here we are using the fine vision trifocal lens. So once the eye is complete, so this is the loading of the lens. So we know how the lens is. So it has these 4 haptics, the leading as well as the trailing haptics. So when we are using these kind of lenses, we need to ensure that it goes into the capsular bag. So watch very carefully. We have to ensure that these leading haptics are in the capsular bag. Now sometimes we feel that it has gone into the capsular bag, but it may or may not have. Sometimes the trailing ones may be a little difficult. So here if you see, if it has not gone, so here what had happened was one haptic was in the bag and the other was in the sulcus. So because of which the capsule at this part has got notched. So if both the haptics are in the capsular bag, you get a nice circular one which is covering the entire part of that part of the lens. But here you get this notch sign. So you have to be very observant and see to it that this is notch explains that, yes. So what you have to do is you just bring the lens towards the center, and then whichever haptic has gone in the sulcus is again put back. So it's important to look at the curvature of the CCC, and then just be sure that all the haptics are in the capsular bag. So it was just a short video, just to be sure that the entire lens and the haptics are in the capsular bag. Thanks.
Thanks, Dr. Anaga. Dr. Ajay, any comment there?
No, I think very nicely said, because this happens in these type of lenses, and especially if pupil constrict even a bit, then it is more tricky because it touches claws in the iris.
Yeah, especially also if the capsular axis is slightly smaller, then it becomes a little more difficult. So maybe you need a little larger.
Way, or when you go inside and just you tilt your wrist so it goes in better there.
Thank you.
Thanks, Dr. Anaga. I'll now request Dr. Sonu Goel. He's going to present his innovation on transscleral modified 4-point fixation. He's quite innovative with all the cortex sutures and all the various G kind of surgeries that I see. So let's see.
So thank you very much. I'll be just like to present innovation in disguise. So this was more of an accidental kind of a thought process when I was just operating. So an idea came, and this is, I name it as the transscleral fixation of a closed haptic design. I call it a 2-in-1 technique. So what actually does this mean is, you see this C-loop design, and accidentally whenever there is a PCR, you tend to suture the 2 haptics here, and then you try to fixate it transsclerally, something like this. So this is a kind of a 1-1 fixation. And usually, most of the studies have shown that these lenses usually end up with lens tilt, so ending up with a large amount of astigmatism. So this is a single point of fixation that can be done with the 3-piece or these scleral supported lenses. So the idea came, and initially we were doing with Bausch & Lomb, but Bausch & Lomb we were trying to do a 4-point fixation. That means 2 sutures were being tied. So what I want to show here is that this isopure lens, since we've been using them, there was a closed library, I didn't have any alternative, I used it and ended up innovating something. So my point here is a very straight simple thought that this lens, taking these 2 points as points of fixation and with the kind of support that they can help us, so the lens tilt can be prevented, and this could prove to be one of the very stable lenses when used for transscleral fixation. Whether you use a 9-Prolene or an 8 Gore-Tex, this would work very well. So the whole concept came up, and this brewed up in my mind, and I came up with this kind of thought that यार इसमें से वीडियो हट गया, नहीं कोई बात नहीं, मैं पहले वो दूसरा वाला वीडियो शो कर दूंगा. So this is what happened to me in the OR, and so this was a patient, trauma, post lensectomy, post vitrectomy. There was a foreign body which was removed, and there was an IOL which was placed. So initially we thought that this was a dangling lens, and it was a Rayner loop design which appeared to us because the lens was trying. The lens we could not make out the haptic. So we took this patient and we thought that we'll transfix the same lens. But unfortunately, as I was just passing the suture, I realized that this was again a C-loop design. And to the best part of it, I was operating the VR-OT and there was no support of infusion at this time. So just watch carefully, this is a C-loop design. So we thought of just explanting it. So I have made an Hoffman pocket here, and I did a Hoffman pocket on the opposite side, 180 degree. There was no Gore-Tex available, so I ended up using 9-Prolene here. So the straight simple, passing the loop from both the ends. So I took this lens inside the injector and just stopped here. So just the 2 haptics, and then this 9-Prolene would pass from one end, loop inside, and then exteriorize from the other end. So it's a simple loop within the closed loop design of this IOL. And then, with a 26 gauge needle, 9-Prolene is trail tracked, and from the opposite end through the Hoffman pocket, I exteriorize it. And now slowly, I roll this lens inside. The incision is close to 3.5 here, and push the lens. The leading haptics are already supported, so there is no chance of the lens getting down. And then I slowly rotate the lens onto the iris. So the trailing haptics, and now the 9-Prolene goes, just watch carefully, from one of the holes here, and I trail track from the opposite side, exteriorize, and then ensure without engaging any corneal tissue here, I again trail track. So the 26 gauge needle comes through the hole within the loop, and then I trail track this 9-Prolene and then exteriorize. So I think within minutes I could achieve this transscleral fixation, a rock stable lens inside the eye because of its unique design. And this is how I pull the 9-Prolene from the Hoffman pockets on either sides. Ensure that the lens is in the center. Never need to titrate before putting a knot. So ensure that the lens is in the center, and I think the Lumera, the 3 Purkinje images are a good aid to the centration. And the second stage was to repair the iris. The iris tissue was deficient all around. But on the first stage, we didn't have an access to the prosthesis, so we thought of going in the second stage. So buried inside and buried this side. Now gradually I'm trying to suture this here. On the opposite side, just titrate and never too tight. And that brings to a very well centralized transsclerally fixated IOL. And this is how the picture of the slit lamp, this is how the lens centration looks like. And this is how day 1 post-op picture. The lens, you almost as if it's inside the bag. So we did an OCT and we did the refractions. There was hardly any cylinder, but there was an error of -1 because of its location, a little anteriorly. But all in all, we were very happy with this kind of technique. Thank you. I think the animation is not working. I would have shown the animation here, but unfortunately, no. Okay.
Very nice, Dr. Sonu. And I mean, the problem with these IOLs is that you can't, usually pre-pass a suture. So what you've done is innovatively, you kind of let the IOL protrude from the tip,
So
pass the suture, and then inject it. So that makes it easier because you've already been able to pass the suture, which otherwise it's very clumsy, and you can have a broken suture, you can have an entangled suture if you try to pass before you put it in the injector.
Correct.
So I think that you've been able to override that, and then
there is no knot inside.
Right.
So that is one, and then it can be titrated because you can pull one end on either ends. You can just titrate.
Very
so
nice.
actually, the most important part is the tilt component and the centration, which I thought is achieved on this case. So many more cases to come, and using 8 Gore-Tex, we'll publish this.
Right. Also, I wanted to ask you that you have to make your incision like maybe 0.2 mm bigger, because once the IOL tip is kind of opening up a little bit in the front, so it won't engage, right? You must have
correct. So I made it 3.5.
Right. So that's fine, because that is still a self-sealing and nice wound. Anything, Dr. Ajay or Dr. Ashish?
No, it's really nice, and the only thing what I want, because the haptics here are little friable because of the material, unlike the 3-piece lenses and all. So you feel that stability of the haptics and tilt and all. This is
this
one
is
case
basically
what we have seen.
that is equivalent to a 4-point fixation now. So there are 2 points on the sclera and the 2 points inside with a width of the kind of separation that they
Normally
have.
with the pull, the haptics are going to be pulled here. So because these are
but these are relatively quite stiff, as well as fragile, not too very fragile, but I think they're going to stay.
No, very skillfully managed, and I think that's what I was going to say. I think it has the advantage of a 4-point fixation with the not
the
the
kind
whole
of
rigor
with a
of
kind of a
doing
single
the
loop system.
Single loop system.
Yeah, exactly.
Makes it simpler.
So I think this lens can be used, internationally, and a lot of studies on this for transcleral fixation. Yeah.
True.
A very easy technique.
Nice.
Thank you.
Thanks. Just stay there, because after her talk, you're going to give that last keynote address as well. Or you can come sit with us here. So I'll request Dr. Afreen Bari. She's going to be speaking on a new monofocal plus IOL, her early experience.
Good afternoon, sir. Thank you for the introduction. I'll just be discussing about the relatively new monofocal IOL and my early experience with it. It's not an innovation, it's my experience with the IOL. There are no financial disclosures. Now, what are the patient's expectations from premium IOLs? Everybody wants to have a spectacle-free life for their daily routine work with a good contrast, without any glares and halos. So there's always been a quest for the ideal IOL. Now this graph tells us the functional outcomes of various IOLs. The multifocal IOLs, they tackle the distance, intermediate and near vision. However, there are associated glares and halos with them. The enhanced monofocals, however, provide an additional edge, providing certain amount of added intermediate and certain amount of near vision. So the Isopure IOL by BVI is one of the new IOLs. It provides premium monofocal, it has a premium monofocal design providing functional intermediate vision without compromising on the simplicity of monofocal IOL, thus providing extended uncompromised vision. As compared to a monofocal IOL, there is around 50% increase in the depth of focus with just 12% decrease in the contrast sensitivity, thus providing additional 1 diopter extended depth of focus. the IOL design, once we see this, it is, as sir also discussed in the previous presentation, it is a closed loop design with around 2 degrees of posterior angulation of the haptics. It is a hydrophobic acrylic glistening free material, and there are 2 injector systems. One is the non-preloaded, the other is preloaded. As we can see, the green line, this is the standard monofocal IOL. As compared to standard monofocal IOL, the isofocal technology which is there in the IsoPure IOL, they incorporate spherical aberrations across the entire optic diameter on both the anterior and posterior surfaces. Now this is what makes it unique and patented to BVI. As we can see here, along the entire optic diameter, there are changes of spherical aberrations incorporated in the IOL, providing progressive adjustment and improvement in the quality. Also, the IOL is customized based on the power. The anterior and posterior surfaces are relatively unique. Like in case of high myopes, in around 10 diopters, there will be a concave convex kind of curvature, ensuring that the lens sticks very close to the posterior capsule. This is how the various powers of the IOL that are available are customized. It makes a very good balance of the depth of the focus with contrast sensitivity and doesn't lose upon the advantages of monofocal IOL. There is no decrease in contrast sensitivity. The material used for the IOL is free from glistening. As we can appreciate here, this is the standard other monofocal IOL. When this has grade 1 of glistening, the BVI IsoPure IOL is free from glistening. This is our initial experience of how the IOL loading is done. Once we open this, we see that the IOL is there in the cartridge. We just have to fix it in the injector. So this is how it is done. Then it's a very simple technique. Once we bring it out, we can see that we have to add fluid here, and then the lens becomes freely mobile. We can see there is anterior movement of fluid and the lens. This is one of the, it also has one of the best delivering systems. As we can appreciate here, as we are injecting the IOL, it opens up very smoothly, and it is ensured that the leading haptics go directly in the bag, and thereafter the posterior haptics are tucked into the capsular bag. The post-operative results show that the lens is very well centered, and the anterior segment OCT of day 1 image shows that there is absolutely no gap between the lens and the posterior capsule. The long-term results are likely to show that this IOL will have less PCO rates. In our results, which we have implanted IsoPure premium monofocal IOLs, we have seen that it provides uncorrected distance visual acuity. Median value was 6/6. Very good intermediate visual acuity with a quite good near visual acuity as well. When there is bilateral implantation, the uncorrected binocular near vision was N8 in that case. There is also a review where multiple studies were collected and analyzed. On the results of IsoPure Premium IOL, it shows that it provides excellent uncorrected distance and intermediate visual acuity, and with a monovision approach, it provides useful near vision as well, with the advantages of monofocal IOL without any dysphotopsias or aberrations. Thank you.
Thank you. I think before can we announce the results and then you can come? Please.
You set it up, he just wants to announce.
Announce the.
You start. I mean, no.
Please.
Actually, he has to leave for the airport, so he wants to just announce and leave.
Okay.
There's no presentation. Only 3D video is showing.
Okay.
दे देंगे दोनों को, तो हम बाद में।
Should I just show, right? So just for the benefit of understanding, I had this small animation, and after making the Hoffman pocket, this is how the 29 nino this is how the suture goes through all the doors, and then basically these are the 2 points of fixation, which is transfixing to 2 entry points on the sclera. So this is how the lens goes in. The trailing, you keep it in the anterior chamber, slowly off through the Hoffman pocket. Take off this ninoproline, and then through the other hole, trail track out, and then you just gently push the lens posteriorly, and then titrate through the Hoffman pockets on either sides. Thank you very much.
So on behalf of the sponsor, I would like to thank all the presenters, presenting authors who have shared not only their innovative devices, but the tips which can be used by many surgeons. Some of the tips which have been seen here is also appreciated by judge that these are the tips definitely of daily use. We could not conclude on the winner and runner-up seeing that the kind of presentations which have been done, so we have increased the number of awardees to get through that, and that now award will be given by the judges. But before that, just I would like to introduce about BVI, that BVI is American company, is a comprehensive, having comprehensive portfolio. It deals in all kind of products which are related to cataract, glaucoma, and retina. But basically in India, we are known for our IOL, which we have acquired from Physiol in 2018, and Opticon, which we acquired in 2018, which is also, we have more than now 600 installation across India. We are here now to reach out to maximum number of doctors. We are trying, from last 6 months, we are expanding our presence. We are trying. We are there for you. If you need us, you can connect us and see that how our technologies can help doctors like you who are servicing in cataract, glaucoma, or retina. Thank you very much.
Thank you, sir. Just announcing
Hello.
So very difficult to judge, because I think everyone presented something which is really good and hard to judge. So we just divided into two. One, we are saying the innovation in the technology, or maybe some new thing, and for that we have 2 joint winners, and Dr. Harshul Tak for his presentation, and Dr. Sheetal Barar for our new innovation, and
joint with
Hello.
the runners up. So the winner for the surgical pearl or a tip, what we are doing is Dr. Sonu Goyal for a wonderful presentation where already present lens can be used for fixated, but yes, definitely it needs more time and for the final conclusions. And the runner-up is Dr. Bhavesh Saha for an excellent presentation and showing us how the Schlemm canal can be reached and the procedure can be done.
We can request all the presenting authors to join on the stage for one picture, please. Dr. Rishi, please. Dr. Arvind, please. Stay here. One photo with the presenting authors. So all the winners and runners will receive a special reward from BVI. We will connect with you and we'll find over that.
Kanaya.